Greetings, everybody. We're going to take a look right now at test number 6. We'll go through chapter 11 and chapter 12, and I'll talk a little bit more about epidemiology, add some additional information that was not covered in the textbook. I'm going to skip over a lot of these, obviously. I'm going to kind of get to some of the test questions. With regards to the positions that are out there, the textbook focuses a lot on government positions. There's a lot of work in private industry. The pharmaceutical industry, in particular, has a great deal of work for epidemiologists. I shouldn't say a great deal of work, but they have work for epidemiologists, but especially biostatistician. If you have a thing for if you have a head for numbers, and you like working with that particular types of software programs, you can do very, very well for yourself. I know biostatisticians that make easily $50 an hour or more, and that's just as a private contractor. So you can do quite well for yourself in this field. The epidemiology positions not quite as prevalent as the statistician positions. Um, Honestly, I think if you met a statistician and epidemiologist, you might have some trouble telling the two apart, but there certainly is a difference. Um, as far as epidemiologists, they're more research based, or they tend to be more research based, more behind the scenes rather than a public health nurse or somebody like a health educator that would be promoting and encouraging healthy behaviors. They tend to be working more behind the scenes doing research type and um, um, influencing regulations potentially to protect against environmental hazards and perhaps influencing vaccine policies, things like that to prevent epidemics. So again, a little bit more behind the scenes. That's probably why most people don't know what epidemiology is. Most people ask me what I teach. I don't even say epidemiology anymore because most people's eyes get crossed when I say it. I just say public health. But monitoring health status certainly a big part. Maybe not so directly the way that a nurse would do, but certainly monitoring the health status within a population. Um, and again, investigating health problems, trying to, especially outbreaks and epidemics. A couple other things, or excuse me, some of the things that they might not do. Again, they're not necessarily out there doing the health promotion stuff. Maybe. I mean, do know epidemiologists that do this, but they tend to be more behind the scenes. Again, not a whole lot of positions out there, at least in the government health agencies. There are some, but 3,000, just under 3,000. The salary isn't bad. Again, if you go into the pharmaceutical industry, they tend to have higher degrees. Oftentimes, they'll have a PhD in epidemiology or public health with a concentration in epidemiology, but then they'll a lot of times also have a medical degree as well or a nursing degree. So it's perfectly good as a standalone degree or as an accompaniment to another type of a medical degree. As far as there's not a whole lot of growth. Some growth, but certainly less than 10%. Only 10 positions. But there's a lot more positions within again the pharmaceutical industry. In fact, I did my graduate thesis with Merck's epidemiology department. It was a very interesting process. So again, much more statisticians, and that looks like a pretty decent growth. I don't know exactly what that is. So 1,400. I don't have my calculator out, but whatever 1,400 positions divided by 7,800 or 6,400. That might be more than 10%. I don't know for sure. I wanted to take a look at that's just what the presentation is. It's pretty brief. I want to take a look at some research studies that have been done in epidemiology, and I think that you'll find some of these kind of interesting. This will work well to accompany the presentation that I did earlier today. Again, this is just a quick case control study. We talked about this. So the cases are people that have a disease. The controls are a group of people that do not have that disease. And then they do a whole evaluation of the lifestyle choices and any other exposures that may be different between the two. In this particular study, they're looking at red meat consumption and risk of cardiovascular disease. And what I tend to do, honestly, is just skim through the abstract here, jump right down to the conclusions. Increased red meat consumption showed a strong positive association with cardiac disease risk. That means that it increases it seems to increase risk of cardiac disease. White meat consumption showed less prominent results, although white meat consumption did still increase cardiac disease risk. Um, and then of course they controlled for confounding factors, which I discussed in the other study. Or excuse me, in the other video. So again, feel free to pause this and read through all the interventions and the results. And if you want to, I'll post this. Actually, this is posted in our Blackboard. You can read through this a little bit more and see kind of how they looked at this. I mentioned this study, and I think I covered this in another video actually. This is a cross-sectional study. So a cross-sectional study is essentially a prevalence study, and it could be in any population. So in this, what they looked at, they carried out a nutrition program, and then they wanted to find out if this nutrition program actually impacted the attitudes and lifestyle behaviors of the people in this group that were exposed to this group. And what they found was that some of this is kind of hard to read, but the hybrid model reflects a more accurate representation of school-based interventions. So the intervention resulted in a significant change in teacher influence on students' attitudes towards vegetables. So I don't think that that's a big deal, but you do need to have these results to demonstrate that your program was effective. So you might not be able to lower obesity necessarily, but at the very least you can demonstrate that there was an impact on the knowledge gained among the population served. Case control group, or excuse me, another case control study looking at, this is kind of funny, alcohol, medicines, and illegal drugs. So the main findings were that alcohol in general caused an elevated crash risk. And cannabis, or cannabis is the official name for marijuana, cannabis also increased accident risk. So the reason I say this is funny is because, like, who does not know that drinking and smoking weed is going to increase your risk of getting in a car accident, right? I think, you ask any emergency room nurse, of course, or anybody that works in an emergency room, and just anybody, of course, drinking and using cannabis is going to increase your risk of getting in a car accident. The reason that they need these studies is because we actually have to document that. We do know that, of course, that's going to happen, but where's the actual evidence that says that this is a real problem? And when we go to create legislation about, let's say, we want to lower the DUI rate, well, the alcohol lobbyists are going to come out and say, well, where's your evidence that consumption of alcohol increases risk of car accidents? And you can say, well, the nurses say it, but that's not enough. You need real hard evidence. And that's why you have to collect this type of research study. So sometimes it might seem frivolous to conduct a study like this, but you actually need the data, to support legislation if you're trying to drive legislation. Or for any other thing, you need the hard evidence. So that's why this type of study is out there. So again, not real funny, but I thought it was kind of funny. A case report. So again, this is an individual situation, not necessarily a clinical trial or a large study with a lot of people, but one person, a 60-year-old man with angina, which is heart pain due to cardiovascular disease. Declined drug therapy and invasive therapy, instead decided to adopt a whole food, plant-based diet. And there is a great deal of evidence now, I shouldn't say a great deal, there is evidence now that using this type of diet, if you can stick with it, will reverse cardiovascular disease. A whole food, plant-based diet is basically it's not necessarily vegan, but it means at least 90% of your diet is based in whole plant foods. And the famous Ornish program, now accepted by Medicare and Medicaid to reverse cardiovascular disease. Former President Bill Clinton used this to reverse his cardiovascular disease. So this is just one case report, relatively new case report, but you need to have more and more of these studies that actually work or that actually demonstrate that you can reverse atherosclerosis um, with dietary interventions. And of course, the case the patient has to stick with the program, but the patient needs an appropriate support program. They need a support to stick with this program, which is where the doctor and the family members need to come in to really offer that support. Because I've been on this type of diet for quite a while, and it's I wouldn't say it's hard because it's enjoyable. The food's enjoyable, but it's hard from a social perspective because it can be hard to find the foods that you need. You have to cook everything yourself. So clinical trial, and I think we pretty much all know what a clinical trial is, but I'm going to go through it anyway. And this is a pretty cool one for a drug. I don't want to try and pronounce that one for type 2 diabetes. And again, 12-week double-blinded, randomized, active and placebo-controlled clinical trial. So you have, one group gets the drug, the other group gets the placebo. Nobody knows who's getting the drug, who's getting the placebo, not even the researchers. The only person that really knows is a pharmacist. And at the end of 12 weeks, we're hoping that there's an improvement within the drug group. And of course, that's what we found. And this is what we need to do when we're doing clinical trials. This is what they do for all clinical trials. All drugs go through this clinical trial process. You have to demonstrate that it is more effective than a placebo. Unfortunately, what happens oftentimes is that these new drugs come out and they demonstrate that they're more effective than a placebo, but they do not demonstrate that they're more effective than the current generic drug that is already on market. And I would say 9 times out of 10, the current generic drug is just as good as the new, improved, fancy, very expensive drug. So that's why it's good to do your research. And the Cochrane collaboration is a great place to look for that. This is what I want to end this particular study on, or this particular aspect of this lecture on, is fish oil. And this is why I highly recommend that you get proficient at learning how to read through these studies. This was the original study, 1989. What they found was that people that ate fatty fish had a 29% reduction in all-cause mortality. So this is where we get this omega-3 supplementation from. This is one of the main sources of evidence that they came out with. What most people didn't realize is that 5 years later, the researchers, same exact researchers, with a follow-up study. So it was that initial study was called the DART study, the Diet and Reinfarction Trial. And this was the DART-2 study, essentially, secondary prevention of cardiovascular disease in the UK. And what they found in this follow-up study was that men advised to eat oily fish, particularly those supplied with fish oil capsules, actually had a higher risk of cardiac death. By this time, 2003, it was too late because they had spent the past 4 or 5 years basically telling everybody to eat fish oil capsules and supplement with some type of omega-3 fish oil or some type of omega-3 oil. And they're really the evidence to support that that overall recommendation was very weak to begin with, but the supplement companies just ran with it. And the fish companies, the fish producers, really heavily supported this idea too. There is some benefit to eating certain forms of omega-3s, but honestly, they come from whole plant foods, from flax seeds. I talked about flax seeds and flax seeds and walnuts and other forms of nuts. Those are really the only forms that you need to get these omega-3s from. And of course, they're much cheaper. Actually, walnuts are kind of expensive. JAMA, the Journal of the American Medical Association, did a huge systematic review. This is the strongest form of scientific evidence that we have for nutritional studies. Not for nutritional, for any study. But the overall omega-3 supplementation was not associated with lower risk of all-cause mortality, cardiac death, sudden death, myocardial infarction, or stroke. So they found absolutely no benefit to taking omega-3 supplementation for heart health. There's never been any study that demonstrated any real hard evidence that demonstrated benefit for neurological benefit for these types of studies. But yet you see these things marketed as being, the next breakthrough. And there's, absolutely no evidence to support the use of these supplements. This is just another study on secondary prevention. So for people that already had a heart attack, to prevent a second heart attack. And this was a meta-analysis, which is essentially the same idea as a systematic review. Insufficient evidence of secondary preventative effect of omega-3 fatty acid supplements. So one of the reasons I started to do this is because last year, my dog, who unfortunately did pass away, I took him to the vet, and the vet was trying to sell me $60 a month worth of fish oil supplements. And I started to do the research. And, this is what I found. If there's no benefit to human health, there's probably no benefit to pet health. But people spend a lot of their money on omega-3 fatty acid supplements, particularly fish oil supplements, and there really doesn't seem to be benefit. Go out and get some whole flax seeds, put them in a blender. You have ground flaxseed, you store it in the freezer. It costs about 3 cents per serving, and that's all you need. Throw away your fish oil. Okay, public health education. So again, this is why I recommend that you really get proficient in learning how to read through health research. You're increasing your health literacy is going to drastically improve your health. Public health education. This is an up-and-coming field. Generally, entry-level public health educator, probably somebody with a BS in some type of health education. It could be a gym teacher, somebody like that. More senior level health educators tend to, I would kind of qualify under that. I've been working at the community college level since 2008. And of course I work at the graduate level at St. Joe's, and I've worked at a number of other colleges too. So I tend to be more people at this point. I'm working for a lot of health education programs. So I'm educating the people who will be working out in the field, working with the public, which is kind of, at this point, I also do some public work as well, but that's more as community health worker, but that's more volunteer work. All my actual pay comes from the colleges. Preventing epidemics, obviously, educating people on how to prevent epidemics and how to prevent the spread of disease, whether you're talking about STDs or just, non-communicable diseases. Obviously, going into workplaces and teaching people how to work safely. Ergonomics is a great idea, promoting and encouraging healthy behaviors in the workplace and throughout the community. Again, not necessarily going in and responding to natural disasters and things like that, but more working with the people. Again, not necessarily monitoring health status, because a lot of times health educators aren't necessarily trained to do that the way a nurse would do. But, of course, public health nurses would make great health educators. But we're focusing more on people that just focus on health education. And, of course, they're developing, just like we're developing our community programs for our health project. Again, as far as the salaries, not the strongest salary that we've seen, but there are more health educators than there are epidemiologists, which is good. A lot of public health information specialists. My guess is a lot of those folks work for places like the CDC, probably the NIH as well, and then again, of course, local folks as well, local health departments. So there's going to be some growth, but not a whole bunch of growth, not a lot of growth, at least in the government agencies. I think we're going to see a huge increase in private industry, particularly for the insurance companies. And because the insurance companies are now going into the corporations, and the corporations now are essentially insisting that their people get healthy, because the corporations are the ones that are flipping the bill for their health insurance, for their workers' health insurance. And a lot of this health education is now being aimed at people working in corporate settings. And my wife actually does quite a bit of that work. So it's a great idea to do that within your own corporation. Okay, I hope this was helpful. Take care.